This lesson is about assessment of my choice participant readiness to change. Objectives for this lesson are to identify the principles and features of readiness to change, and then examine what prevents behavior change, and to provide examples and tools for use when conducting readiness for change. Let's get started. Here's some background information about readiness to change. Helping participants change behavior is an important role for clinicians. Change is useful for addressing disease prevention, like mammograms or smoking cessation, or disease management, like a diabetic diet or daily weights. Participant non-adherence and motivation often focuses on failure, while understanding readiness to change, appreciating barriers to change, and helping participants anticipate relapse can improve participant satisfaction while also lowering clinician frustration during the change process. Here's our first checkpoint. Why is change useful for addressing disease prevention and management? Is it understanding the readiness, guides, support coordinator actions, or is it helping participants anticipate relapse can improve satisfaction while also lowering the clinician frustration with the process? Or is it both? The correct answer to this is both. Here is some more information. Readiness to change is built upon the trans-theoretical model of behavior change, which assesses an individual's readiness to act on a new, healthier behavior and provides strategies or processes to change, to guide the individual through the stages of change to action and maintenance. Readiness to change is composed of the following elements: the 5 stages of change, the processes of change, self-efficacy, remember we had a lesson on that earlier, decisional balance, and temptations. So here are the 5 stages of readiness to change: pre-contemplation, contemplation, preparation, action, and finally, maintenance and relapse prevention. Let's discuss each stage. The first stage is pre-contemplation. Most often, participants do not consider changing. They may not believe that their behavior is a problem or that it will negatively affect them, or they may be resigned to their unhealthy behavior because of previously failed efforts and no longer believing they have control. Here's a few examples. A smoker who's in denial may not see that the advice applies to them. A participant with a high cholesterol level may feel immune to the health problems that strike others. Or an obese participant may have tried unsuccessfully so many times to lose weight that they have simply given up. There's also many other examples of these types of issues in my choice participants. We could go on and on. One thing we know is that at the pre-contemplation stage, motivational interviewing is a tool that works very well. We'll cover that in our next lesson. In the meantime, here are some simple and easy pre-contemplation questions that could be used by the clinician in the My Choice program. The goal of the conversation is to have the participant begin to think about change. Using these types of questions, what would have to happen for you to know that this is a problem? What warning signs would let you know that this is a problem? Have you tried to change in the past? This will help the participant to think through a change and to talk about the change and what it would mean to them as a person. Often, this type of conversation provides understanding for the clinician of the desire or lack of desire to change so that the clinician knows what to do next. Nothing if there's no desire to change, or if there is desire to change, to work with the participant to make a change. Here's another checkpoint. You're seeing a participant who believes that their high cholesterol will not lead to health problems like heart disease or a stroke. At what stage of change is the participant? Contemplation, pre-contemplation, or preparation? The correct answer to this is pre-contemplation, not considering a change. So the second stage of readiness to change is the contemplation stage. Participants are often ambivalent about changing and many times do not express their feelings. Giving up behavior causes a participant to feel a sense of loss despite the perceived gain. Struggling with ambivalence, weighing the pros and cons of their current behavior, helps a participant to make a choice to change or not. During this stage, participants assess barriers like the expense, the hassle, or their fear, and also the benefits of the change. Motivational interviewing works really well at this stage. Here are some simple and easy contemplation questions that could be used by any clinician in the My Choice program. The goal here is to help the person examine the benefits and barriers to change. Try using any of these questions. What do you want to change at this time? What were the reasons for not changing? What would keep you from changing at this time? What are the barriers today that keep you from change? What might help you with that aspect? What things have helped in the past? What do you think you need to learn about changing? This again will help the participant to think through a change and to talk about the change and what it would mean to them as the person. Next is the preparation stage. This stage occurs when a person is preparing to make a specific change. They may experiment with small changes as their determination to change increases. Here are some examples. Sampling of low-fat foods to experiment with or move towards greater dietary modification. Or switching to a different brand of cigarettes or decreasing their drinking signals that they may have decided the change is needed. For this stage, cognitive behavioral therapy works really well. We'll have a lesson on that later. And the fifth stage is the action stage. Most clinicians are eager to see participants reach this stage. Any action taken by a participant should be praised because it demonstrates the desire for lifestyle change. Cognitive behavioral therapy works really well here too. So maintenance and relapse prevention are included in the final stage. Incorporating the new behavior over the long haul is difficult. Discouragement over occasional slips may halt the change process and result in the participant giving up. Most participants find themselves recycling through the stages of change several times before the change becomes established. A combination of motivational interviewing and cognitive behavioral therapy work well at this stage. So here's what a readiness to change scale looks like on paper. Here's this scale is used by clinicians worldwide to assess a participant, patient, or person's readiness to change. Many clinicians use this scale and it helps to guide their actions from none, the person does not want to quit smoking, to providing education, medications, or other supports, like a smoking helpline to quit. It takes less than 2 minutes to use the scale once you get used to it and use it on a regular basis. The scale has a score of 1 for pre-contemplation to 4 action and maintenance. And many clinicians use half points when a person is in between a stage. The box in the upper left includes the first question. Does the participant acknowledge a deficit area? If the answer is no, that leads to either box 1 or box 2, pre-contemplation or considering trying, which is contemplation. If the answer is yes, that leads to the lower left box question. Does the participant indicate willingness to try different changes to help make daily life easier? If the answer is trying, that leads to box 3, preparation. If the answer is yes, that leads to box 4, action and maintenance. Keywords in this scale are consider trying, and yes and no. Using the readiness to change scale provides a clinician insight into where to expand their energy. If a participant does not acknowledge a deficit area, like smoking harms health, and is at the pre-contemplation stage, no actions should be taken. However, if you're at the contemplation stage, Awareness of the deficit can prompt consideration for change. So to evaluate readiness to change, you can use change talk, which occurs naturally. So if you get a person that's thinking positively about change, then elaborate with them, affirm them, reflect upon the change, and summarize. However, if there's no interest in change, then apply techniques for eliciting change talk. This all needs to happen prior to developing a plan. So here are some questions to elicit change talk. What changes do you want most? On a scale of 1 to 10, how important is it to you to change? What are your most important reasons for changing? Or, in what way are you already able to make changes that you want to make? And finally, what steps are you willing to take, and how will you do it? These are change talk questions. So here's another checkpoint. Change talk communication technique works well when assessing readiness to change. The answer to this is true. Change talk works. So here's a case study of a real-life My Choice participant who received the model of care in our pilot study. This participant had been in the My Choice program for 8 years, was an 83-year-old female who lived alone in a house. She had a history of arthritis, COPD, CHF, coronary artery disease, hypertension, non-ruptured cerebral aneurysm, lupus, anxiety, depression, and diabetes. Just prior to this care, she had an MRI which showed she had several bulging discs in the lumbar region, degenerative changes, narrowing, and scoliosis. She reported chronic pain, fluctuating blood sugars, and difficulty completing household chores, as well as getting in and out of the tub or bath and shower. Her goals were to improve her IADLs, strength, walking, and mood. Her person-centered service plan was to improve her IADL tests, strength, walking, and mood. Within her readiness to change scale, the issue she admitted to sometimes feeling helpless and depressed because she couldn't take care of her home and needed as much help as she could get. She had a brother who lived in the county, but due to his health problems, only talked to him by phone. Both the nurse and social worker conducted a readiness assessment and found her score to be between contemplation and preparation. The readiness assessment focused the care. Based on the assessment, they recommended and encouraged reinstatement of CLS aid services to assist with her IADL needs. This was a highly satisfied care recipient who used all 3 services, OT, nurse, and social worker home visits, to improve her quality of life. Here's what she said. The program really helps you feel mentally and physically better. The information that you provide helps us stay in our home and is great. Getting my CLS worker back to help with chores like laundry has been a blessing. I really appreciate my CLS worker and the agency she works for. I feel like I can stay better in my home. In summary, use of the readiness to change scale to determine if a participant wants to change is important. Clinicians need to develop techniques to assist participants who will benefit from behavior change. Traditional advice and participant education does not work with all participants. So understanding the changes through which participants pass during the process of change can successfully change behavior. But the care, when we do this, needs to be tailored. The methods in this lesson can be applied to many areas of behavior change. Thank you.